Hello, everyone. Good afternoon. I am Dr. Parag Salkade, working as a diagnostic radiologist in Department of Radiology, Sengkang General Hospital, Singapore. I would like to thank the organizers for inviting me to give this presentation, and especially thanks to my close friend Vinod Varghese. Thank you very much. Today's topic is on effect and impact of COVID-19 on global healthcare system, and especially in the Singapore context. But almost all healthcare systems around the world are reeling under tremendous pressure. I'll also be speaking on some imaging spectrum in COVID-19 infection. As we already know and already alluded by my previous speakers, we are dealing with an unprecedented crisis where lives and livelihoods are involved. Main aim is to minimize the loss of lives and livelihoods where all the governments are struggling to prevent. We have already seen the economic shock of this COVID-19 pandemic, and maybe we enter into a prolonged economic recession in post-pandemic period. Therefore, a close coordination between the public sector, healthcare delivery system, and our individual behavior is required, and we should all follow the given WHO guidelines. As we all know, COVID-19 is a respiratory tract infection, and we need to contain it within the containment zones that has formed by now. And in order to have sufficient time at our hand or at our disposal to increase the capacity, for example, increase the number of beds in our healthcare system, like for example, ICU beds, number of ventilators and drugs, N95 masks, and all those things. And the success of curtailing this pandemic depends on how the demand and supply are managed in coming months. As far as anecdotal evidence is concerned, the public policy and hospital practice levels responses will last for at least 3 to 4 months, or maybe more in some countries. Till then, we have to collectively suppress the infection and buy some time. In order to successfully tackle this pandemic in a very determined way, it is paramount to understand the disease profile based on scientific evidence and available data. It starts with the naming of the virus and learning the characteristics and key features of this virus, which was named by International Committee on Taxonomy of Viruses, called as Severe Acute Respiratory Syndrome Coronavirus 2 or SARS-CoV-2, and the disease was named by the WHO as coronavirus disease or COVID-19, which is a respiratory tract infection. And this is an electron microscopy of the coronavirus CoV-2. As per the WHO data, the number are rising at alarming rate. And as of 12th of June 2020, when I prepared this talk, about 7.4 million confirmed cases have been reported, including about more than 400,000 deaths reported by WHO. This was declared as a pandemic on 11th of March 2020, and the coronavirus was named on 11th of February 2020. As we all know, the definition of pandemic means almost every citizen all over the world in every continent are involved. And as we are learning this disease, we need to keep, or we need to understand the basic three T's of this infection. That is, we need to train, or we need to track the disease in order to flatten the curve. Then we need to test for coronavirus. And lastly, the third T is tracing, the contact tracing. So coming to the first about trending and tracking, these are the first 10 most affected countries in the world as a 5-day moving average. And it is important to flatten the curve by wearing masks, social distancing, lockdown methods, and all those things we have followed since last few months. And these are the case fatality ratio per 100,000 population, and India is about 0.63 as of 12th of June 2020, which is quite reassuring compared to the other countries in the world. There are basically two types of tests. One is for the active viral infection, which is called as the swab test, where we take the swab of the nasopharynx and detect the virus replication. And the second is a serology or a blood test, where we detect the antibodies from prior infection. And regarding the contact tracing or digital tracing, I think this is also one of the most important aspect of disease containment. And with the use of this digital technology, I think the tracing has become quite fast and feasible, and everyone should download this digital tracing app, provided that it is evidence-based and has good governance and accountability. Most important is the public engagement to contain this disease. As far as the global hospital policy is concerned, it may differ from country to country, but these are the broad categories that I can think of, which can be divided into two: macro levels and micro levels. Most importantly, at the government or a senior management level, you can have a multi-specialty or a multi-ministry task force so that the communications are quite seamless and with no distortions, no fake news, which is very important in this current age of WhatsApp University or social media. So communication should not be diluted or in a way it should be quite genuine based on the scientific evidence. And another would be to expand the capacity of our beds capacity, both in basic bed capacity as well as the critical care beds, and also the lab testing capacity, because as you know, this is a recently developing infection and we may not have that many test kits. Also, in the same sitting, we have to manage or control other outbreaks that may happen during this rainy season, maybe, or like for example, malaria or maybe dengue fever, which is common in Singapore context. Also, the vaccination program for our younger generation, it should not be hampered in any which way, so that they are protected. At the hospital level, I think we need to curtail all the non-urgent and elective care, and all the staffs are provided with this contact tracing app. We in the hospital have RTLS or radio tagging method, which is even faster and more robust. So we can detect people in contact with these patients. In order to alleviate the strain in the healthcare system, we may have to defer some non-urgent surgeries as well. So we have to look at that operation theater list and all those outpatient OPD list and everything. And it takes a lot of time to call these patients, to repostpone them. And most often the patients may not turn up for all these their own surgeries and their appointments, for example, cardiologists or orthopedics for chronic problems. And they may want to defer themselves also. So a lot of no-show rates at the hospital level. As far as the micro levels are concerned, each and every department, all the staff members, they have this policy of twice temperature records. It is via the app, and where possible, we have distributed thermometers to needy people as well as lower middle class staff members. We have distributed thermometers, masks, uh, free of cost. And we have engaged all of them in refitting exercises because N95 masks are very important to manage COVID-19, and they come with different vendors have different sizes, and they come at law. Therefore, a fitting exercise is required. Protective personal equipment, drugs, rationing should be preserved because at the start we had a limited supply, and therefore the central distribution points were established so that we know who is taking for what, and that is how the rationing was done. Of course, at the level of the roster management and work from home options were given, those who can work from home, and then we divided teams into two, like dirty team and a clean team. The dirty teams were managing the COVID positive patients, while clean team were managing the non-COVID patients. So there were two distinct teams that were working around the clock. We had staggered working hours and shift duties. Like for example, in my department, the shift duties were like from 8:30 to 5:30 p.m. and the second team would come at around 12:30 p.m. to about 8:30 p.m. And then the on-call team will take over for the night calls. So also technology was used in a large extent. For example, for everybody, for staff, hospital staff, and even for the general public, we had a safe entry and exit app that they have to download, and so that we can do the contact tracing more efficiently. For in terms of doctors who were going from one institute to other institute, because, for example, surgeons going from our hospital to other hospital for renal transplant, for example, or other high-end surgeries, this cross-institutional flow was suspended actually, so that we don't get infected or we don't transfer infection from one hospital to the other hospital. In Singapore context, the Ministry of Health declared DORSCON orange level at on about 7th February 2020, and the multitask force declared a circuit breaker that we call here for lockdown on 3rd of April 2020. These are the few, sorry, not few, but these are the confirmed COVID-19 positive cases in Singapore, and we had about 25 deaths. And this is the updated data as of 12th of June 2020, active cases in the community and discharged cases, which are more than the active cases, which is a good sign, and flattening the curve. Would like to explain about this DORSCON level that the Singapore government introduced in 2006 for disease prevention and response. It is called as disease outbreak response system condition, and there are 4 different alert levels graded from green to yellow to orange and red, and where if now is the orange, where the disease is severe and spreads easily from person to person. That is the definition of DORSCON orange level in short. In addition, technology was also used for the public to use regarding their symptom checkers. It was in all the languages, and they have to answer yes and no whether they are elderly or young population. And also this app was introduced so that they can go to the nearest GP clinic or general practitioner clinic and show their symptoms, whether it is really COVID positive. They can do the swab test, and accordingly they were managed, sent to bigger hospitals. And this was a sign used to show that public health preparedness clinic, you can go to show your um, symptoms and get assessed by qualified doctors. In addition, in anticipation of increase in number of cases, because we have a limited capacity in the hospitals, all those COVID positive patients which do not have complications like pneumonia and all, they were housed in cruise ships, multipurpose halls. They were converted to single room beds, and homestay order was also passed by the parliament as an infectious disease control act, and they were all catered nicely while they were staying home for 14 days. Even the stadiums, they were given temporary shelters, those who were workers from nearby countries, for example, Malaysia. And these patients were actually monitored very closely by our hospital, and once they turned negative, then they were released back into the community. So actually what happened in Wuhan, in Hubei province in China. So this is the article published in Lancet, which is the most respected journal in medical community, and they published these clinical features of patients infected with 2019 coronavirus. And these patients were exposed to seafood market, and they were all diagnosed with pneumonia of unknown cause. Most important thing was the timeline after the onset of illness. The data was showed was from December 16, 2019 till Jan 2nd, 2020. And this is the time of onset of illness. And that is why we know that the incubation period for this infection is between 1 to 14 days, and the median is about 5 days. Symptoms can be varied, but mainly it is the upper respiratory tract infections and viral pneumonias. You may have other symptoms like diarrhea, conjunctivitis, headache, loss of taste and smell, and rash on the skin. Few patients, they went into respiratory failure called as acute respiratory distress syndrome, where you require nasal flow oxygen, ventilator support, and few patients were also managed by lung transplant surgery, which is a quite complex surgery. Healthcare workers, while managing these COVID positive patients, were affected as well, about 4% in China. These are the few early images, CT scan chest images of patients in China, where patient 1 is the upper panel, patient 2 is the lower panel, and over the period of 15 days, this infection progressed over a period of time. This is another patient where CT scan chest shows significant extensive pneumonias in both the lungs. And they isolated this virus from these lower respiratory tract specimens. And it is important to understand that a genomic sequence was detected by deep sequencing analysis or real-time reverse transcription polymerase chain reaction, or in short, RT-PCR method. And this is the basis of developing a diagnostic test to detect this coronavirus. And as of today, we have test kits all over the world. So this information was shared by China to WHO and other countries where they can develop this genomic sequence and develop test kits. Of course, there is mutation risk. Viruses can mutate into other strains, and we need to understand the genomic sequence for adding it into our test kits as well. So it's like a continuous process. These are the few examples from other parts of the country. For example, Korea, Japan, Hong Kong, Singapore. All patients had these bilateral pneumonias in both the lungs. This is a patient from Hong Kong. And the lower panel, this patient is from Singapore. He was a taxi driver who was ferrying a Chinese tourist all over the place, and then got admitted with this viral pneumonia and was had a lot of tubes and catheters in his body and was managed well. So coming to my second talk, which is on imaging spectrum of COVID-19. So we have to do a lot of things on the operational side of our department. And we also need to understand the imaging spectrum, how this disease looks like actually, and how to know that this is not any other viral pneumonias. So these are the examples of the chest radiograph, which shows a pneumonia on the left side in this mid-zone. And on the CT scan, there are multiple areas of consolidation, or rather we say ground glass opacification, as marked by the arrows in both the lower lungs. So most of this infection was around in the mid and lower areas, unlike in tuberculosis, where we have a lot of infections in the upper areas. So we know that respiratory tract infections need to be assessed by chest radiographs or chest X-ray and or CT scan. So these are the mainstays of imaging in COVID-19 patients. And chest radiographs are available all over the world, is like easily available and performed. And sometimes we require thin section CT scans to assess the gravity of the disease, as well as to assess the complications of the disease from this lung infection. Actually, the threat of infectious disease to Singapore is not new. We had this SARS crisis in 2003, and as an offshoot of that, we built a purpose-built infectious disease hospital, actually a 330-bed hospital. And during this pandemic, we expanded to accommodate about 500 beds of COVID patients. And instead of one ICU of 38 beds, we increased to 2 ICUs of 38 beds each. All other hospitals, including my hospital, doubled their regular capacity in last few months. When we had this first case on 23rd of Jan 2020, which was an imported case from Wuhan, China. And we also know that the chest X-ray or X-ray radiology imaging is an important or integral part of any respiratory tract pandemic situation. But in order to cater to so many patients at one time, we need to reconfigure our daily operations. So on the operational side of our department, we had a lot of planning and coordination to be done, and we need to stabilize our workforce. That was the most important thing. And second important is to protect our own workforce to help mitigate this crisis. All safety measures were deployed, like for example, PPE, masks, distancing, and hand hygiene and sanitizers. And it is important to note that we have this hand hygiene testing done for every 6 months, routinely also without pandemic or otherwise. We also have this temporal segregation and spatial segregation done between the staff members, and we also restricted the staff interactions during lunchtime and coffee breaks, and more stricter infection control measures were employed. Decontamination of the rooms was adhered to, but more strictly this time, and use of technology was encouraged for all the meetings, education, and also for planning and coordination of all activities. We had all the support from our senior management with heightened security at the entry points of the hospital, with thermal scanners at the place at the entry points, and all the wards, not all wards, but few wards where these COVID positive patients were housed, they were negative pressure isolation rooms, single pass airflow system, and some of the cases rooms were given an ultraviolet ray treatment. Segregation of flow and materials was demarcated, and management of the waste materials was also demarcated. A dedicated corridor was used for patient transfer from wards to our imaging department. And most of these were segregated for both COVID and non-COVID related patients. Because we need to continue to provide urgent care to non-COVID related admissions and emergencies. Although we postponed most of the elective cases and interventions, we provided telemedicine or teleconsultation, and with of course at a reduced consultation fees. Most of these elective surgeries and appointments were rescheduled, more robust system or streamlining of the system was done for all cancer patients and pregnancy related issues. Most importantly, it was discouraged doctor hopping, because patients may go from one doctor to another doctor and increase the burden on healthcare system. It was discouraged strongly by the Ministry of Health in Singapore. Of course, while we work in healthcare system, we have to take care of ourselves, protect ourselves, but we have to still monitor our exposure from illnesses so that we can get quarantined on a timely basis and do not infect our colleagues. Otherwise, the healthcare system will collapse. Um, if uh, if we are healthy and most of us, touch wood, uh, were quite protected from this infection till now, and but our junior colleagues were redeployed for managing other services. For example, those patients housed in resorts or cruise ships or multipurpose halls called Expo, they were deployed there to manage these patients. So our workforce went down, but uh, we still have to provide round-the-clock services. So that was challenging. Research at the hospital level was suspended. Exams were all postponed. So we had a lot of impact of this pandemic situation. This is how an X-ray, a portable X-ray of a COVID positive patient is done in the ward. And these are the X-ray of the COVID positive patient showing infection and which got resolved in 7 days time. Patient did not require any oxygen supplementation. This patient presented with fever and cough uh, in our hospital. So these are the staff members doing the CT scan. The area is all draped, and PPE, surgical mask, face shield, shoe covers, gloves, all were provided, and we took care of our staff quite diligently. And ultrasound machines were all draped in protective plastic. This is the patient waiting area where social distancing was observed. So we divided the department into 4 organic teams comprising members of different subspecialty, and teams were segregated in different areas because we have to still provide round-the-clock service. And as you know, the nasopharyngeal swab test results were available in 24 hours time at initial period, not now, but initially was 24 hours. So we have to do, so when the patient comes in, we have to do the swab test, we do the chest radiograph and go. That policy was adopted by the Ministry of Health at our hospital. And we have to report this chest radiograph as fast as possible. It was done in less than 1 hour. And it was a new operational challenge because round the clock service and reporting so many patients at one time was a difficult task. But we try to mitigate this crisis in a very successful way. Most of the rooms that were used were designated as dirty rooms. And after the rooms were used for doing x-rays or CT scan, a terminal cleaning was activated, which typically takes about 60 minutes to completely thoroughly clean that room. So it takes a lot of time and stress of our staff. This is another case which actually, unfortunately, the patient worsened with fever and cough. This was the initial X-ray showing bilateral pneumonias, which got worsened over a period of 5 days. Some patients may undergo, may have complications and may go into respiratory failure where you require a high nasal high flow oxygen and ventilator support. These are the few cases that we had with ARDS, called acute respiratory distress syndrome, and the patients are intubated with tubes and all, and there is extensive pneumonias on both sides on chest x-ray. On CT scan there is extensive pneumonias in both the lungs, and another patient showing the same findings, patient 2, and eventually it had a prolonged course and patient improved. But some cases, most of the cases are very mild cases where you have mild pneumonias everywhere. And this is from our hospital with state-of-the-art imaging, which shows iodine maps and perfusion around that area to understand the disease pattern, uh, new disease pattern basically. All along, we have to maintain the staff morale and the safety is to sustain this pandemic situation. And compliance was necessary. Like for example, daily temperature taking and safe entry and exit of the premises, proper donning and doffing, the gowning up and gowning down of the PPE, and refresher course of powered air purifier respirators, that is called PAPR, and again retesting or refitting of the masks. More importantly, we had these mindfulness sessions, 5-minute meditation, so that we can sustain over a period of time and maintain staff morale. Technology was used for our conferences, meetings, the graduate education, and it was a global phenomenon. And most of us used WebEx and Zoom for our planning, coordination, even tumor board meetings, clinical radiological rounds, and interprofessional education, as we are doing it now for you guys. Unfortunately, some patients have complications secondary to COVID-19 infection. For example, pulmonary embolism, which is blood clot within the pulmonary vessels causing obstruction and associated pneumonia that is seen in this patient. There is blood clot inside the pulmonary vessel and pneumonia in the lungs. Another patient may have blood clot in the brain and causing stroke. There is an infarction developing on the left side of the brain. And some patients may have myocardial edema or heart disease and may succumb to these findings. If patients are COVID negative and still have irreversible lung injury, for example, you hardly see a normal lung in this case. And these patients, they underwent lung transplant surgeries. They have already done few lung transplants in China, and couple of lung transplants done recently in US also for saving these patients, usually young patients, 30, 40 years of age with whiteout lung. And these are the lung specimens of the COVID-19 infection. And after the lung transplant, that is post-transplant, they are improving. So it's a life-saving surgery, but very complex surgeries and should be done because we don't know the disease pattern, how it behaves and all, and should be done with a multidisciplinary approach. So in conclusion, the threat of COVID-19 is far from over and continued vigilance is paramount. Every crisis presents an opportunity to refine our practices. As it is called the new normal, we continue our efforts to understand and battle the disease. And we should continue to take all necessary precautions. So stay safe, stay well informed, and stay compliant because we have to prepare for ourselves for second surge. Who knows? These are the references from the scientific literature, and we published these findings in one of the local journal, Singapore Medical Journal, and we would like to acknowledge my chairman of medical board and the head of the department at Sengkang General Hospital, Singapore. Thank you for your attention.